Good morning, everyone. I'm Dr. Alluri, and I'm a specialty registrar in Sheffield Teaching Hospitals NHS Trust. And I'm going to present to you a service evaluation which myself and Dr. Wrench, a consultant anaesthetist, conducted in our maternity unit on allogenic blood transfusion rates in cell salvageable obstetric patients. So I'm going to plan this talk around first talking about I'm going to cover the reasons and names for the service evaluation, and then tell you about the methods of the service evaluation and discuss our results and provide you with our conclusions. Starting with the background, Joseph Wing Maternity Unit is a 24-hour surface tertiary referral center in Sheffield, and it's attached to the Royal Hallamshire Hospital. And here we have about 7,500 deliveries per year, and cell salvage was introduced into our unit in 2007. And as in our hospital, we don't have any of the specialties that regularly use cell salvage, like cardiothoracic or vascular or orthopedics. We had to set the service up so that it's entirely run by the obstetric theatre staff. And we did this after a 2-month period of training and education of the departmental staff. And we decided to use this whenever there's an anticipated blood loss which would necessitate an allogenic blood transfusion. And by this, we hope to reduce our allogenic transfusion rates and also to maintain the cell salvageable skills of our theatre staff. And by using this, we wanted to, and we found that the use of this was cost effective, which was found out by our service evaluation, which we did in our unit previously, which is highlighted here. Sorry, stand here. And also the benefits of cell salvage blood include that it's readily available, and it avoids all the difficulties with cross-matching. And also we have less risk of transfusion reactions. And also there's a less risk of infections, which was highlighted in here we decided that we did talk about transfusion-related sepsis as the leading cause of maternal mortality here. And it also comes with some theoretical risks of amniotic fluid embolism and hemolytic disease in future pregnancies. There have been recent studies and recent papers in the BJA recently, which still say that there's still theoretical risks, and we still don't have enough evidence to say that the cell salvage cannot be used because of these reasons. And talking about Cell Saver, can I just ask the audience about how many people have first-hand experience of using cell salvage? I think it's very few. So what I'll do is I'll just talk to you about how a cell salvage is used. Showing you in the picture here, this is a hemonetic cell salvage machine which we use in our unit. And in this, it's just got a reservoir into which we suction the blood from the intraoperative field. And in here, the blood along with the saline is then filtered to clear out the major debris. And then from here, the blood is taken into the bowl where it's centrifuged and it's processed. And the waste is collected into the bag, and pure red cells are collected into the transfusion bag, which is then transfused to the patient afterwards or during the operation. In our unit, we use it to transfuse immediately or within the first 6 hours since it's collected. And this is a picture of the disposables we use for the cell salvage. And this is a leukodepletion filter, which we always use to transfuse the patients. So the aim of our study was to compare the allogenic perioperative blood transfusion rates in obstetric patients where cell salvage was suitable and appropriate prior to introduction of cell salvage and after the introduction of cell salvage to our unit. So how we did this is a retrospective study for which ethical approval was not required, and we pulled the information and cross-referenced it from the theatre, blood bank, and labour ward databases. And we collected the information onto a Microsoft Excel spreadsheet, and from here manually we identified the cases suitable for cell salvage and also the number of allogenic transfusions received by these patients. And we analyzed the data for a period of 12 months prior to the introduction of cell salvage. In this, we assume that if we had cell salvage, this is the number of cases that would have had cell salvage. And for a period of 24 months afterwards, after the introduction of cell salvage. And in these 24 months, not necessarily all the cases that were suitable had cell salvage used in them. And this is a slide which shows us our criteria for suitability and unsuitability. If you look at the first table in here, this grossly covers all the cases of cesarean section, which is emergency to elective, in which that is suitable for cell salvage. And most of them include the cases of abnormal placental implantation, and cases with previous history of postpartum hemorrhage or cases with history of antepartum hemorrhage, And cases in where you expect an increased blood loss due to atonic uterus, like in multiple pregnancy, it's a cesarean section at full cervical dilatation, or a repeat cesarean section at three or more cesarean sections. And we also include a criteria of a low hemoglobin of less than 10 grams per deciliter, because in a study in our unit before, we found that an average drop in hemoglobin during a normal cesarean section was about 2.5 grams per deciliter. And in our unit, we had a transfusion trigger of 8 grams per deciliter, and we were aiming for a post-transfusion target of 10 grams per deciliter. So that's why we included a preoperative hemoglobin of less than 10 grams as an indication for cell salvage. And also we added a criteria of multiple uterine fibroids, which would add to an atonic uterus afterwards. And grossly, the unsuitability criteria were cases in which the blood in the operative field was contaminated with bacteria, as in vaginal blood loss. So we had to exclude a lot of cases with PPHs, which had vaginal blood losses, as being unsuitable for cell salvage. So in this table, I'm going to show you the results of our service evaluation. In this, we had, if you look at the first chart, this is data for 12 months prior to the introduction of cell salvage. And we found that 72% of these cases would be suitable for cell salvage if we had the machine then. And of them, we had 5.6% of the cases that received allogenic blood transfusions. And coming to the 24-month period after the introduction of cell salvage, here we had 75% of cases that were suitable for cell salvage. Here I have to agree that not all the 75% of cases had cell salvage used in them. And in here we had 4.4% of these, of the 75% of cases that received allogenic blood transfusion. And since we had cell salvage used here, we had 3.6% of the cases that received allogenic blood transfusion. And in the next slide, I'm going to show you just these parameters in a graphical depiction. Looking at this is our allogenic blood transfusion, percentage of cases that received allogenic blood transfusion prior to introduction, and this is afterwards. And so here I can show you that we had about 1.2% drop in the reduction of percentage of cases that had allogenic blood transfusion, which just provided us with a significant p-value of 0.042. And though we had 3.6% of cases that received cell salvage blood, our drop in allogenic transfusion rates were only 1.2. And this could be explained that as cell salvage technique is used only for intraoperative blood losses, we had some cases which would have lost blood or continue to lose blood out of theatre, which cell salvage could not be used, or as I said, all of the cases, all the suitable cases might not have been targeted in this period. So to discuss this, the use of cell salvage in obstetrics in the UK has been endorsed by these major organizations, the AAGBI, the OAA, and the NICE. And NICE provides technological guidance based on the cost effectiveness and the best available evidence available to them then. And it also provides patient information leaflets on the use of cell salvage, which most of the obstetric units in the UK who use cell salvage use them. And this is an initial service evaluation which we did in 2010. Where we considered all the theatre cases and all the allogenic blood transfusion cases in them, and here we didn't find a significant reduction in blood transfusion rates. As you could see, we had our transfusion rate in the unit was about 7.6%, and it did drop slightly, but then went up in the period of 2009. So, in our current evaluation, we increased the specificity of the cases which we choose, in that we only selected cases that were suitable for cell salvage, and we only looked at the allogenic red blood cell transfusion rates in them. And by this, by increasing the specificity of our criteria, we found that we had a significant reduction in blood transfusion rates in these patients. So I would like to conclude my talk by saying that use of cell salvage in appropriate and suitable cases, obstetric cases, may significantly reduce the allogenic blood transfusion rates in them. So I would like the topic for questions now. Thank you.